Thank you. Thank you. Again, I think it's about 10 years ago that we did the first patient support group meeting after I'm not supposed to call it KCC. I've called it KCC for 10 years, but apparently we're branding ourselves as Kidney Cancer Canada instead. So that we did one of these. And over the years, when Karen asked me to speak at these, I can never say no. So here I am again, and people must get sick of hearing me speak at some point. So I guess I'll keep coming so long as you keep asking, Karen. And anybody, I know a lot of you in the room, and apparently there's over 90 people online listening. And so for anybody that knows me, I walk very fast in the clinics, and I talk even faster. So I will try my very best not to talk as fast as I do in the clinic. But I do also know that we have really good discussions at the end of these sessions. Both people write in online questions and then in the room as well. So I want to make sure we leave lots of time for questions. And the title, I was given recent developments in kidney cancer, and I kind of went a little bit over, all over the place a little bit, but there is a method to my madness here, so maybe we'll just start. When we give when we talk at medical conferences and things, one of the first things we have to do is put a disclosure slide to show that we're not biased, or maybe we are biased. And so this is what we would normally include. And so I sit on advisory boards for a number of drug companies. And the reason for that is so that we can learn, from my point of view, the reason I do it is so we can learn what's coming up. One of the most important things for me is so that I can know about clinical trials coming down the pipe so that Atlantic Canada isn't forgotten. Sometimes because we're a smaller center, they concentrate in places like Toronto, Vancouver, and Montreal. I think it's very important to try to always have something available for our patients in Atlantic Canada. And so that's why I sit on those. I do get money, I give it to charity, so I don't think I'm biased that way. I do research with all of these drug companies, and again, I don't personally take money, it goes to the institution to fund the research project. In terms of diagnosis, Karen touched on some statistics, but again, 70–80% of kidney cancers actually now are diagnosed incidentally. You happen to have an ultrasound or a CT for some other reason. In Nova Scotia, it tends to be for gallstones. Do you have gallstones and you happen to pick up a kidney tumor at the same time, not dissimilar to an abnormal blood test that we just heard about. Most have masses confined to their kidney. Some do present advanced, and some that are localized to start with do spread after. And again, just in terms of cancer lingo, because you've all heard your doctors and nurses use different terms. So lump, tumor, spot, nodule, mass, cancer. We usually mean all the same thing, and that's cancer. Sometimes people do have small nodules, for example, in their lung, that we actually don't know what they are to start with. But usually when the term mass and things that are used, it does mean cancer. I'm not sure if some people use that term to make it gentler on patients, and we could have a full discussion on what term you actually would rather have as patients. And as well, in terms of kidney cancer, it's the same as renal cell cancer, it's the same as RCC in my terms. And we'll talk about the most common pathologies in a minute. There are a few exceptions to this. Often the pediatric cancers wouldn't be considered renal cell cancers, but they're cancers that start in the kidney. So for our sake, those three terms all mean the same at the bottom. This is what a kidney looks like, and you can develop cancer in any part of the kidney itself, and that's where they sit. Many of you have only one of those in this room. In terms of an overview, there are different pathologies. The most common is called a clear cell, which is also called conventional. That probably makes up 80–85%. Papillary, and there's type 1 and type 2, and now under type 2, there's actually two different types. Chromophobe. There's often a mixture of those. Some people don't have a straightforward one, and there's actually a mixture. And then there's other rare types. There's 4 stages of kidney cancer. So one of the most, Kidney Cancer Canada has done well is educate patients to ask a lot of questions, and you often come in with checklists. And one of the questions I get asked is, what stage is my cancer? And we usually review that, but it's 1 to 4. 1 is a very small mass in the kidney. 4 is it's gone somewhere else other than the kidney. So kind of where are we now and where we're going? And there have been major, major advances in kidney cancer since 2005, essentially. That's when really things changed. And it's largely because of research. And so a lot of this topic is going to talk about research, mostly clinical research. And even though many of you aren't on clinical trials, the treatment that you're on came to us because of clinical trials. So I think it's really important to kind of understand how we got to where we are. And a lot of these were really discovering finally the genetics of cancer and finding out what's different in a cancer cell compared to your normal cell, and then exploiting that difference. So trying to target that difference. And we've targeted different pathways. So again, some people have heard these terms and others not, but one pathway is the VEGF pathway, the mTOR pathway, the c-MET pathway. And then what we're going to spend a lot of time talking about is the checkpoints in the immune system, that pathway. So tonight we'll kind of focus on what is research, advances in kidney cancer research. I'm a medical oncologist, so I tend to see people with advanced kidney cancer, so we're going to focus on that because I will never talk as if I'm a surgeon. And then talk a little bit about what's on the horizon. And in terms of research, you know, that's a huge, broad term. So there's many types of research. So there's basic science research, and that's what happens in a lab, in test tubes in animals. There's observational studies. So looking at a whole group of people from Nova Scotia, are there higher incidence of kidney cancer near the tar ponds versus not? Those types of studies. Those are also called cohort studies. Clinical trials, which I'll explain a bit more, and then qualitative research. So things like quality of life. If you're on drug X versus drug Y, even though they may be similar, what's the quality of life difference between those two sets of drugs? And if it's different, is it worth it for patients? So again, what do patients value? Those type of things. And again, the idea is that you learn something in the lab and then you gradually move it into the clinic. That's the concept of bench to bedside. So this is kind of my simplistic view of cancer. It's a seed growing in soil. And now the question is, what makes up the seed and what makes up the soil? So this is a diagram of one minuscule part of the soil. So again, it's meant to overwhelm you because it overwhelms me. And that's just one very small pathway in the soil with which cancer cells grow. So you can imagine trying to figure out what do we target there in that minuscule piece of soil and in all the other parts. And that's the challenge, but also where we've made so much headway. In terms of clinical trials, so again, those are patients that enter a study. There's 3 phases, a 1, 2, and a 3. And a phase 1, you've got a brand new drug. Is it safe to give humans? And what is the dose to give humans? So they're usually studies of anywhere between 16 and 20 people, and you get a sense of that. And how you decide something's safe, in the old days when it was chemotherapy, the side effects usually happen quite quickly. So you could give somebody a drug and you could watch them for a week, 2, 3 weeks and see what happened, and then decide whether you went up on the dose or not. Because a lot of chemotherapy side effects, which you may or may not have read about, but are things like lowering the blood counts, sores in the mouth, diarrhea, all that happened early. With our newer drugs, the question is, what's the time frame you have to watch someone to know there's not going to be a side effect? And are any of them going to show up with a side effect 9 months later that we didn't look at in the first 1 to 2 months? Phase 2 study, you've now got your dose and you know your drug's safe. Does it work? So you try it all in the people with the same type of cancer. So whether that be a kidney trial or colon trial, and does it work? And traditionally we count work as shrinks the cancer, but we'll talk about this in a second. And then a phase 3 are the big studies. So the phase 3 is you have your brand new treatment and you compare it to your old treatment. Which one's better? And by better, we usually mean survival. Do we make more people live longer? But sometimes it's a different endpoint. Do we actually make people live better? Do we make them have less toxicity, things like that? So how you tell if a drug works is in oncology trials, and for any of those that actually read trial information, I know some in this room do, a response rate is a shrinkage. So does your cancer actually shrink? And we all have the same definitions across the world. So if I do a clinical trial in Halifax and they do a clinical trial in Switzerland, our definition of response rate is the exact same. And basically it's the sum of up to 5 lesions, and a 30% shrinkage in those 5 is considered a partial response. And so everybody then you can kind of compare across the board. Another endpoint is clinical benefit. So do you shrink the cancer or keep it stable? In kidney cancer, stability is a very good thing. It's not shrinking, but so long as it's not growing, that's a good thing. Progression-free survival is, do your x-rays get worse over time? And the hope is that they get worse later as opposed to earlier. Time to progression. So again, if you're on a new drug, do your x-rays get worse, or do you clinically get worse in 6 months or 6 years? That's an important endpoint. And then the biggest one is obviously survival, cure rates. Sometimes we look at disease-specific survival. And so, for example, prostate cancer, which tends to affect older men, if you're 80 when you're diagnosed with prostate cancer, and you might pass away of something other than your cancer. So say you've got a 10% risk of dying of your heart disease, but only 2% of your cancer. What we really want to know is, do we affect your cancer mortality as opposed to your overall? Because sometimes the treatment can actually kill people. So again, if you happen to save 2% of people from their cancer, but 4% have side effects enough to make them pass away, your treatment's not good. So that's why sometimes you'll see disease-specific or cancer-specific survival. And then surrogate endpoints, which would be really nice to have. So for example, in lab data, so in testes cancer, there are two very, very good tumor markers. One is called a alpha-fetoprotein and one's called a beta-HCG. So you've got them elevated, you give somebody chemo, they should come down. If they come down, you know it's working. If they don't come down, you know it's not. In prostate cancer, we have PSA that is not as helpful as in testes, but it's still helpful. In kidney cancer, unfortunately, we haven't identified anything yet. There's a lot of work on that, but wouldn't that be nice? If we could just have a blood test to say, yes, your cancer's there. No, it's not there. Yes, it's responding, but we don't. And the other thing is an endpoint. So if you're targeting the VEGF pathway and you have a high VEGF to start with and a low VEGF after the drugs on board, it should correlate, but it doesn't at all. So we don't have anything at all in kidney cancer that helps us that way. And then quality of life. Do we make people feel better? So there's different ways to measure this. One is performance status. Are you up and around doing things? One is weight loss, weight gain. Some cancers cause a lot more weight loss than others. Some treatments cause a lot more weight loss than others. So are we actually measuring that? Pain. And pain is a common one in prostate cancer, for example, which tends to go to bone. And then we also look at analgesic use. Does our treatment allow them to use less pain medication? And then quality of life questionnaires, and I've got two different words under there, FACT and EORTC, and those are just worldwide recognized quality of life questionnaires. So if any of you have been involved in clinical trials, you've probably filled out more than one quality of life questionnaire. In the clinic, we tend not to use those. To go on a study, you have to have an REB or IRB, which is your Research Ethics Board approved. So I can't just go and start treatment A on any of my patients. So it has to be approved, and then a patient has to meet a number of eligibility criteria. And unfortunately, it has to kind of be the cream of the crop because the biggest thing is to do no harm to patients. And you have to consent to it. So if a patient doesn't consent, you obviously cannot go on it. And so there was, in the past, and why this is a big deal in the past, and I don't know if any of you have read books about it, but they didn't have patient consent. And so, for example, they used prisoners, or they on clinical trial, not clinical trials, or impoverished people that had no option. You either go on the study or you don't get a treatment. And so that would not be allowed in 2018. And then some of the other things we look at in kidney cancer that kind of allow you to decide whether somebody's going to be fit for a trial are these things called prognostic factors. And I'm bringing it up now because it's important in a minute, but performance status, again, your fitness, what your red blood cell count is, which is hemoglobin, your platelet count, your white count, your calcium, and the time between diagnosis and treatment. When you put those together, if you have none of the bad features of those, you're considered a good prognosis. And if you have 3 to 6, it's worse. And that's not saying that everybody does worse. It's just when you look at large populations of patients, those 3 groups of patients tend to do different. And so when they plan a clinical trial, they want to make sure that they're distributing those equally. So one group of patient doesn't have a lot more negative prognostic factors than another. And so again, this is my only localized kidney cancer slide because again, I would not want to speak as a surgeon, but the advances in localized kidney cancer are really kind of what our speaker spoke about earlier is nephron sparing. So the nephron is the unit of kidney. So you want to save everybody's kidney as much as possible. So for example, if you can do a partial nephrectomy, they try. Now sometimes they can't. If it's right in the center or if it's a certain size, then it's just not possible in some cases. And also improve techniques, sometimes when they clamp the kidney to take it out, they'll use warm ischemia. Sometimes they'll use cold. So whether you use heat or cold or things like that, the amount of time that they actually have the clamp on and things like that. So people over the years have made advances to try to make it so when they're in there, they do the least damage possible to your normal kidney. And then there's a lot of advances in guidelines with regards to the Canadian Urological Association. So for anybody that's had their kidney removed, and again, I know it's one of Kidney Cancer Canada's real mandates to get out the education for people that have localized kidney cancer, how you should best be followed, and that you're your own best advocate. And so the old guidelines are, I think, 2007. So in the coming months, there's going to be a whole new set of guidelines. And again, it's that balance between scanning and seeing people enough, but not going crazy so that we're not giving you too much radiation. Or you may have heard of the term scanxiety, where just the thought of the scan causes profound anxiety in people, and that can be very significant from quality of life point of view. And then they also have a guideline in what are called small renal masses. So they're also SRMs. So small renal masses are small kidney lesions, often less than 3 centimeters. And the question is, do they all need to be taken out? And so again, they've got guidelines on that. And that's where, again, having people that are familiar with the management of these is important. So for advanced kidney cancer, so people who had a kidney cancer that spread somewhere else, in 2017, and you'll notice I didn't put 2018, in 2017, there were really 4 options. So one is observation or surveillance. Some people, for whatever reason, have very slow growing disease or not growing at all, or it's very small volume, say 2 or 3 lung nodules, or completely asymptomatic. So in people like that, it makes sense not to jump into treatment right away, because there's no question treatment is going to affect your quality of life. You can't get treatment and not have some side effects. And so for some people, we can watch them for several months. For some people, we can watch them for several years. So that should always be an option. Certainly if you're sick from your cancer, it's not a good option unless that's your choice to not have treatment. And then sunitinib and pazopanib, which are 2 VEGF inhibitors, and then a clinical trial. So what's new in 2018, I'm going to talk about 3 kind of main themes. 1 is the timing of kidney surgery. 2 is some new second-line options we have. And 3 are some new, very, very new data on first-line options. And first-line means it's your first line of treatment after you've been diagnosed with advanced kidney cancer. And so in terms of surgery, when your kidney cancer is spread and you decide to take the kidney out, it's called a cytoreductive. That means getting rid of mass, nephrectomy. Nephrectomy means getting rid of your kidney. And when you think about it, it's the only cancer that when it's spread, we actually take out the primary tumor routinely. So you wouldn't do that for colon cancer or breast cancer, lung cancer, but we do it for kidney. And that's because there were 2 trials in the past, and they were the late 1990s, early 2000s, when we had old treatment, and they randomized people to the old treatment, which was interferon, compared to surgery plus interferon. And the idea was if you got rid of that big bulky tumor, you'd have a better response to the immunotherapy. And what they found is the responses were the exact same, but just the act of taking the kidney out did make some people live longer. The important thing, though, is it's a very subset of patients. It's not all patients. So there's definitely people that don't benefit from taking it out. So then everybody said, well, now that we have such better therapies, should we still be taking people's kidney out even though it's spread? And people hummed and hawed about the studies, and nobody could ever really agree. And so it took a long time to get the studies going. And in the end, there were 2 studies. One is a French study that hopefully the results are actually announced in June. And this one is the study that was announced a year ago. And it was called SURTIME. And it looked at doing the surgery first and then starting on sunitinib, or doing a little bit of sunitinib, then the surgery, then a bit of sunitinib. So it was a timing question. Everybody got surgery, but when should you do it? And the problem is, in 6 years, it only accrued 99 people. And we had 4 centers open in Canada. We accrued 3. And for a bunch of reasons. And sometimes the urologist was very passionate that the person should have their kidney out, or passionate that they shouldn't. Patients were often passionate, I want my kidney out. That's kind of a North American thing. Get that thing out of there, I just want it gone. And just for a whole bunch of different reasons. So they ended up having to stop the study early and change the statistics a bit. But what they found was, in the end, if you look at that first column, so 50 people had the immediate surgery, 46 went on to receive drug, and 34 went on to receive the surgery. And that's probably because those people progressed in between. And the other are 48 out of the 49 got the surgery. Delayed. 48 ended up getting sunitinib, and only 26 went on to get their surgery. And when you look at the progression rates, they're the same. The surgical complication rates, they're the same. And the side effects of the drug, they're the same. So basically, it kind of came out, it may not matter. What's interesting, though, is the survival actually did look a bit longer if you had your sunitinib first, and then your surgery. But the numbers are not powered for that. It stopped early, and so we can't make conclusions. But what we know is we're not harming people by not doing the surgery up front. So that's kind of what we got out of this study. Now, whether the French study, the good thing is the French study was able to accrue all their patients, so hopefully we get more results in June from that. So, yeah. And then in terms of second line options, so say a person's had sunitinib or pazopanib, it either didn't work or stopped working. Prior to 2016, we had the bottom two, axitinib and everolimus. So axitinib is kind of like sunitinib. Everolimus works on a totally different pathway. And then in 2017, we had data on the top two drugs. So nivolumab is an immunotherapy, which we're going to talk about in a second. Cabozantinib, don't you love the names? I'm going to quiz you all later. Targets a different pathway that's new, and that c-MET pathway is actually an important one in papillary cancers that are hereditary, but it looks like it also plays a role in clear cell kidney cancer. So now we have 4 options. The question is which one is better than the next, and which one should we use, and what's the right order? And it's a tough thing, and unfortunately in Canada, sometimes it comes down to funding. Which one as the provinces have they funded, and which sequence have they funded? And sometimes that's the deciding, and what I try to do in the clinic is what's going to give us the most options. And sometimes that's the reason I choose that order, is let's try to have as many options as possible. So we're going to spend a bit more time on nivolumab and drugs like that. And because that's what a lot of people are hearing about, and if any of you are on some of the kidney cancer websites. So it's an immunotherapy. It's also called immuno-oncology. It's also called immune checkpoint inhibitors. They're all the same thing. So again, we used immunotherapy back in the 90s in kidney cancer, and that was interferon. We all make interferon. We just gave big, big doses of it. And so what we know is, and why the immune system is important in kidney cancer, is we know that there's people, even with advanced disease, where the cancer can spontaneously go away. So it's obviously somebody's immune system that's doing that. The other thing is we have lots of patients who, despite having kidney cancer spread, it doesn't grow or grows very slowly. So again, we're speculating that the immune system is doing something to help those patients. The other cancer that's like that is melanoma. And so a lot of work has been done on that. And then in the 2000s, really, there's been this explosion of information on what the checkpoints are, what keeps the immune system in check. And so basically, you've got white blood cells that normally should attack things that are foreign, so viruses or bacteria or cancer. And so the question is, why doesn't our immune system recognize that the cancer cells are foreign, and why can't it just attach to them and get rid of them like we do a bacteria? And what we know is that there's a whole bunch of checkpoints or breaks on the immune system, and they're listed, some of them are listed there, there's many others. And they keep a balance on the immune system so that you can't turn it on or off in some cases. And so it's like a light switch. How do we turn the immune system back on so that your immune system can go ahead and fight your cancer? And so these are, and I'm so sorry, it's very small. I borrowed these slides from someone, they're referenced at the bottom. So you've normally got your cancer cell, and your normal white blood cells, in this case they're called lymphocytes, should go and attack that cell. But the problem is the cancer cell expresses these proteins on it, and in this case, let's just say it's PD1, or PDL1, sorry, that's the name of that protein expressing, and it basically puts a blindfold on the white blood cells. So the white blood cells can't recognize it as foreign, and so nothing happens. So what we're going to do now is introduce a drug, and that's the orange things, that are going to attach onto the blindfold so that we unmask it and your immune system can fight again. So again, the another analogy I use is we're taking the brake off the immune system by these drugs. And so,
doing that now?
So yes,
You do that.
yeah. So the orange ones, well, let's keep going. So this is a drug, that nivolumab. So it's the other, it's in this middle there. The trade name or the marketed name is Opdivo, but which I don't know if the marketed names are, I think they're actually worse sometimes than the others. So the red circle is your cancer cell. And that PD-L1 is a protein that it's expressing on its surface that you don't want there. And then the green cell is your white blood cell. And so those two things are attached. So now the blue drug comes in, and so that can't attach. So now now your white cells can recognize that the red cell is foreign. Okay, so that is how nivolumab works. And there are drugs right now that attach to the orange part, and there's now drugs that attach to the yellow part. So they're either called PD-1 inhibitors or PD-L1, depending on which cell they attach to. Clear as mud? Okay, everybody has to draw this later. So how are they given? Unlike all the other kidney cancer drugs that we use routinely, we went away from IV chemo, we went to oral targeted therapy, and now these are intravenous. So they're either every 30 to 90-minute infusions, every 2 to 4 weeks, depending on which drug it is. And you always need blood work and assessment before, just like when you're on the other drugs. And so now I'm going to talk about 3 different combination trials that have really come out in the last 6 months. And I abbreviate things because, again, they're just too long. So nivolumab is Nivo, and then we'll talk about the others as we go. The drugs on the first drug listed is the immune treatment, and the other drug listed is often a different mechanism. One of the good things and bad things is they went to combination therapy right away. But every time you combine things, there's more side effects. So again, one of the things would be, well, what about single agent? Can you get as much bang for your buck if you're using just one drug instead of 2? Most of them, though, have been combinations. So the combination of Nivo-Ipi, Nivo is that PD-1 inhibitor, and the Ipi, or ipilimumab, but Ipi just targets a different checkpoint. So same concept, just a different checkpoint. This combination is not yet Health Canada approved for kidney cancer. It is for melanoma, and all of the work on this combination first came out of melanoma. And metastatic melanoma is a cancer that has a very high mortality rate. And this combination can now actually cure people with metastatic melanoma. And so it's remarkable. The problem is it's not everybody, and you can't tell ahead of time who it is. And it's really made a huge, huge difference to that patient population, and hopefully kidney cancer as well. So I put this study design in just to kind of show you when we report at meetings, this is the kind of slide that goes up. So the first box is the patients. So no prior treatment, advanced clear cell kidney cancer, and unfortunately a lot of trials are clear cell, and not too symptomatic. So again, it says KPS, but that stands for the performance status, over 70. So that means you're up and around. So if you were bedbound, sick from your kidney cancer, you wouldn't have been allowed to be on the study. It was randomized 1-to-1. So half the people got treatment A, half the treatment got treatment B. Treatment B was standard care, sunitinib. Treatment A was this combination. And essentially, all you need to know is it's given intravenously about every 3 to 4 weeks. And then basically the endpoint, which is the far box, is you keep treating somebody until they progress or side effects. And this is kind of, again, a typical table of what we would present. So in the first set of columns, it's all patients. And this is important to pay attention to because the results are dependent on this, even though they may not make sense. So all patients, and then the column towards me is intermediate and poor risk. So if you remember that slide earlier, these were patients that had at least some negative things. So you were anemic, or your platelets were high, or something like that. So everybody's around, the median age of kidney cancer is around 60, and that's who these patients were. About 70% of people are male. And then, as you can see, that prognostic score, about 23% had no negative features whatsoever. And that's typical of a kidney cancer population. And then the very last box is just for interest. So again, the PD-L1 expression. So if you look across that very last line, about a quarter of people express more PD-L1 on their tumors than not. And again, that's going to come up in a second. So only about a quarter actually, when they measure it in this way that they measured it, had a lot of that on their cells. When you looked at nivolumab, which we currently have Health Canada approved for second-line therapy as a single agent, when you looked at to try to figure out did it work in people, that PD-L1 status made no difference whatsoever, which doesn't really make sense, right? You would think that if there's more on the cells, the drug should work better, but that didn't pan out. Okay, with me so far? Okay. So in the results, what they showed, and this is important, so drug toxicity is that second line. 24% of people had to stop because of toxicity in the combination compared to 12% on Sutent. So for anybody that's been on Sutent, you can imagine at times you did want to stop. And the median number of doses, though, was 14 on the nivolumab, anywhere from 1 to 63 in some people, and the IPI was 4 doses, which is what you were supposed to give. So the point here is that not all patients can tolerate it, unfortunately. And what they found was that the overall response rate, if you took all patients with a Nivo IPI, and again, this is very specific for clinical trial, measurements, somebody looking at it independently, was 39% compared to 32% with sunitinib. But if you looked at the intermediate or poor risk, it was 41% of people shrunk with the combination compared to 26, and 9% of those were a complete response. So in 9% of people, it went away completely compared to only 1% with sunitinib. So that's the key. Who are those 9%? How do you figure out who those people are so that you can give the drug especially to those people? And what was interesting, though, in the good risk patients, so with no negative prognostic features, 52% of sunitinib people responded compared to only 29%. So in the good risk, it was the opposite results. And a possible explanation is that these checkpoint inhibitors work better in tumors that have a lot of mutations in them, so a lot of genetic abnormalities and things like that. And maybe those people with all those genetic abnormalities have the worst cancers, so a lot of inflammation. And when you have a lot of inflammation, your hemoglobin goes down, your platelets go up, your white count goes up, things like that. So maybe it correlates with that. And maybe that's why the drug combination worked better there. Whereas sunitinib, you don't have as much inflammatory mutational burden and stuff. So maybe the targeted therapy is better in that patient population. But the answer is we don't know. So this is literally all within the last few months. So again, there's a lot more data because as many of you know that are on trials, we collect a lot of extra blood and samples and tumor and stuff like that. So all that's going to be analyzed. But the company has submitted for Health Canada approval, and it will be approved. Again, the key for me and you is who should we use it in? And when you look at health-related quality of life, which is important, so did we actually make people feel worse or better? 60 is kind of the number on your far left. So that's kind of where people started. If you're above that, you did better on that drug combination if you're below that. So despite that many side effects, the people on the combination immunotherapy actually had a better health-related quality of life than the people on sunitinib. Not by a lot, but just a little bit. So again, that combination, it's many people, it's again, for anybody that's been on sunitinib, you know it's that kind of chronic, the taste change, the fatigue, the diarrhea, maybe a little more than a little bit in some people. And the immunotherapy doesn't tend to cause those in the majority of people. When you do get it, though, in the minority of people, it can be bad. So that's kind of, and so what are the side effects? So if you take the brake off the immune system, your immune system can then fight your normal tissues. So it can be inflammation of any normal tissue. So brain, eyes, bowel, etc. The ones we care about the most are inflammation of the lungs, that's called pneumonitis, or the bowel, which is called colitis. So it'd be shortness of breath and cough, or diarrhea. In the blood, I check the liver, I check the endocrine organs, so things like your thyroid and your adrenal gland, to make sure that it's not getting inflamed, because if they do, their function shuts down and you need replacement. So it's a lot of patient education going on these. People can have allergic reactions. It's very rare, but you can. And then some people feel tired, although again, compared to sunitinib, not as tired. And so in summary, from this trial with the Nivo-IPI combo, there were more complete responses. There was a higher survival in patients with the intermediate and poor risk disease. And in this study, people that had a higher PD-L1 expression actually did do better. And that's different than the other kidney cancer trial. But interesting, sunitinib was actually better in low risk patients. Okay, so this is a first line option that may come in 2019. I can't see it coming this year. And it's looking at atezolizumab, which is simply a different drug company that's making one of these. But instead of working on the PD-1, it works on the PD-L1. So it just blocks the opposite side, along with bevacizumab, or Bev. So what Bev does, interestingly, it works on the same pathway as Sutent does, but it works outside the cell instead of inside the cell. So the side effects can be different with it. So what they showed is the response rate. So 37% of people responded compared to 33, but the duration of the response was longer, and there was less progression, and the side effects were less. But more people did actually stop it because of the side effects, so 12 versus 8%. So these were very preliminary results, and there's a lot more data coming out on this combination. And then again, whether this comes out in 2019 or not, so again, it's different, Pembro, so again, a different drug company, along with axitinib. So axitinib is a lot like sunitinib. It's just very similar. The interesting thing with sunitinib and post-operative, you cannot combine them with any other drug. When you try to combine it with anything, the side effects are just too much. So for the oral drugs, this is the only one that seems to be able to be combined with something. And they just reported this recently. It was only 52 patients, but the response rate was 73%. So it was that's one of the highest ever reported. Phase 2 studies, which this is though, tend to take even better patient population. So it might just be a biased number of patients. But again, complete responses in almost 8%. So complete means you cannot see it on an X-ray again. So those again are just kind of some of the nivo-ipi we talked about, the atezo-bev we talked about, the pembroaxitinib we talked about. The ones in red are the ones that we had going on here in Halifax. So the accrual's over and we're collecting data and stuff, but those are the ones we had. And then there's some others going on as well across Canada and across the world. So it's a good thing, but it's also going to be a bad thing, because what if they're all better than sunitinib, and now you have 5 combinations that are better? Which one's the right one to use? And the only way you really know that is then to compare X and Y and Z, and but that uses up a lot of time and uses up a lot of patience. So it's a good problem to have too many choices, but it will make it difficult. And you can see just even this discussion is pretty overwhelming, and we haven't even really talked about specific side effects yet. So you think I'm behind in clinic now. I think I'm going to get a little bit further behind in clinic, because there's so much to talk about and to make your decisions. And again, one of the booklets that Karen has at the front there, it's the International Kidney Cancer Coalition. So they tried to develop this book to help with shared decision making, so that it's not the doctor making the decision, it's not the patient, that it's a shared thing. They're going to have to add several hundred pages again to get all this information in, because again, it's what you value. If a longer survival but a worse quality of life is what you value, well then your opinion counts. If quality of life is the most important, you might want to run out the door right away. And the biggest problem is you don't know who it's going to work in ahead of time, and you don't know who's going to have side effects ahead of time. The only way to know those things is to try it, and that's the dilemma where we're at right now. So this is just kind of not meant to you to read it. It's meant to tell you all the different drugs that we have now for kidney cancer, and those are listed as single agents. So again, then when you start combining them and stuff is the dilemma. One thing I just did want to mention is the use of both local therapy and systemic. So whether you're on a clinical trial or not, sometimes you'll be responding really well to your drug in all places except one. And so what we've learned along the way is you should treat that one differently. So either try to take it out with surgery or try to treat it with radiation. Radiation was sometimes limited in the past because old techniques, you had to give quite a big volume to get a big enough dose in. And now there's something called SBRT, which is stereotactic body radiotherapy. And it's a technique where they can get a dose of radiation in, a much more focal dose at a much more smaller area. And so because of the higher doses, you can actually get a bigger dose in for kidney cancer. So what we don't know today is, again, what the best combination is. What's the best sequence? Maybe you don't even need a combination. Maybe these should all be single agents, just sequenced one right after the other. And then one of the other big questions is, what if you've had your kidney out and you're at a higher risk of it coming back, so it was a bigger tumor or it was a little bit uglier looking under the microscope? Do any of these treatments work in that setting? And so far the answer is no, but there's lots of clinical trials ongoing with all these newer agents. one of the difficulty things is when you're potentially cured from your kidney cancer, and it could be, you don't know if it's going to come back or not, your willingness to undergo side effects with some of these treatments is a lot different than when you actually know that it's affecting your cancer, because when it's done in the post-op setting, the treatment's probably at least a year. And when the people are on the drugs, you can't tell them if it's doing anything or not. And it's really tough to sit through side effects when you don't know if a drug's working, compared to somebody when your kidney cancer spread, I can tell you if it's shrinking or not. So at least we know that it's doing something. So the good news is, the really good news is there's always ongoing research. And every single week we're learning something new. And so we're only going to move forward in this field, and we'll never be left behind, because we're always going to know something new. And the end of the day, the goal for all research and all clinical care is to improve patient outcomes and to improve your quality of life. And that should be the goal of every piece of research we do. And so when I kind of did this slide, I thought, okay, why don't I just Google and see what's come up? Although I did also know these topics. But what's on the horizon, these are two concepts I'm going to introduce that are really quite cool, is the gut. So this is actually from April 10th, 2 days ago, and it was in Nature Reviews. And the first author is actually a medical oncologist that's now at the University of Montreal, very smart person. And this is the title, The Gut basically, the biology in the gut influences anti-cancer, immunosurveillance, and general health. So this is the kind of summary. Discoveries made in the past 5 years indicate that the composition of the intestinal microbes has a major influence on the effectiveness of anti-cancer immunosurveillance, and thereby contributes to the activity of immune checkpoint inhibitors that target the white blood cells, as well as activity of immunogenic chemo. So the gut bacteria can potentially change the outcome of your treatment. And they actually go on to describe actually which specific bacteria they found and things like that in this. So I'm not sure though yet today we can say that eating the probiotic yogurt makes a difference or not, because what we don't know is really which ones are important, which ones aren't, how do you get them, how do you not get them. And then this is a second one that is from March. So it says there's a negative association of antibiotics and clinical activity of immune checkpoint inhibitors in patients with advanced kidney cancer and lung cancer. So then the summary is antibiotics were associated with reduced clinical benefit from these checkpoint inhibitors in kidney cancer. Modulation of antibiotic-related environment may be a strategy to improve clinical outcomes. So again, one day, are we going to give people a certain antibiotic or avoid certain antibiotics just to change the milieu in the gut? And will that actually change therapy? So this work's not only being done in kidney cancer, but there's a lot of work being done in colon cancer with it as well, where you can actually see bacteria in the cancer itself. So stay tuned. We don't know the whole picture, but there's going to be a lot in this in the coming years. And then the other thing is genetics. Genetics. How do we take your tumor, figure out what's wrong with your tumor, and figure out what treatment to give you specifically? And this is again this is a bit older, but from October. And Samara Turglik, she was a guest speaker at our kidney cancer forum in February that Karen had mentioned. And this is one smart lady. So basically their lab, and they're at the Crick Institute in London, they've looked at tumor heterogeneity. So they've taken a kidney cancer and they've done 20, 30, 40 biopsies from the same tumor, and they've found different genetics even within the same tumor. And then they've looked at the metastases and tried to link it to the genetics from the primary tumor. And so the problem is it makes you think, oh my goodness, how do we deal with this now? But just knowing that's important. And what are the driver mutations? So if a tumor has 20 mutations, well, what are the first ones that are really important? How do we figure out what those are and then again affect those? So this is kind of the way of the future, this genetic stuff. And I'm glad there's very smart people to help sort it out. As Karen mentioned, the website has a lot of information on clinical trials. Here in Halifax, the current two we have is a papillary kidney cancer trial that's in North America. And again, it's the first randomized papillary clinical trial ever done well, actually, maybe it's not, but it's one of the few because it's uncommon compared to clear cell. And then the other one is an adjuvant trial. So again, if you have your kidney out, but you're at higher risk, do one of these new immunotherapy treatments help you or not help you? And And we'll leave it at that with a calm day at Peggy's Cove. So if this was a picture for the rest of Canada to make you envious that you don't live here on the east coast of Canada. Thank you.